Hello friends, welcome to the All or None Law lecture videos. So we will continue our lecture series on the hypertension. The first video that we put up was the quick overview of hypertension. So the subsequent video lectures will be on the pharmacotherapies, and the number one we'll start off with is the thiazide diuretics. Um, According to the JNC 8, the Joint National Committee, the 8 guidelines that were put up, I think approximately 3 years ago, if I'm not wrong, 3 or 4 years ago, 3 years ago, I think, wherein the thiazide diuretics were considered not to be the first line of therapy. As a matter of fact, they were considered to be the second line of therapy after calcium channel blockers and ACE inhibitors. All right, so let's start off with the different types of very commonly used thiazide diuretics. So clinically what we use, and this is what we're going to try to focus onto. So number one, the most commonly used is the hydrochlorothiazide. The number two is chlorthalidone. Number three, indapamide. And number four, metolazone. I put up metolazone. It's not primarily used in hypertension. It's mostly used as a diuretic for patients who have loop diuretic resistance, and that will be a separate topic in itself. But I just wanted to bring this medication up because it is one of those medications which is very commonly used in clinical practice. Now, the top three medications, hydrochlorothiazide, chlorthalidone, and indapamide. Among these three, the most rampantly used medication is hydrochlorothiazide. What is interesting is we have data or evidence on chlorthalidone and indapamide. uh, Data is not so much on hydrochlorothiazide, a robust data, but in clinical practice, for some reason, hydrochlorothiazide is more famous. You can figure out a reason for that and let me know. What is the mechanism of action of these medications? So all the diuretics tends to act at the functional unit of nephron, which is the functional unit of the kidney, I mean, which is the nephron. And the mechanism, the site of action of thiazide diuretics is the distal convoluted tubule of the nephron. They blocks the sodium chloride channel, and this is what you need. They act at distal convoluted tubule of the nephron. They block sodium chloride channel. So when you block the sodium chloride channels in the distal convoluted tubule, as you lose all the sodium, that is nothing but the natriuresis, and there is some loss of water with sodium, and that's why it leads to a little bit of fluid loss, and that's why it is classified as diuretic. But it has a predominant action on reducing the blood pressure, so it's a good antihypertensive, but not a very potent diuretic like a loop diuretic. And when you look at the nephron in itself, the proximal convoluted tubule is where around 60% of the absorption of the water as well as electrolyte happens, and then there is a countercurrent mechanism exchange as well as fluid, water, and electrolyte reabsorption in the loop of Henle, and around 10 to 20% is reabsorbed back from the distal convoluted tubule. So by blocking the distal convoluted tubule, you are essentially preserve affecting the reabsorption of that sodium as well as to some extent the water. So remember three things. It acts at the distal convoluted tubule of the nephron. Number two, it blocks the sodium chloride channel. And number three, it causes natriuresis. What are the side effects because of these things? The most common side effects that I have listed. Number one is the hypokalemia. Hence, you recommend patients in getting a metabolic panel checked as you start these medications, and you need to sometimes replete them with the potassium. Number two is a hyponatremia. As you saw, it is a predominantly natriuresis causing medications. Hence, you tend to see hyponatremia with thiazide type diuretics. Whereas with loop diuretics, it's the other mechanism. So it makes you lose more water, and hence you tend to get hypernatremia, not hyponatremia. In a very small percent of the cases you might, but predominantly this is what you should remember for boards. Thiazide diuretics will cause hyponatremia, whereas loop diuretics cause hypernatremia. Hypomagnesemia, hypercalcemia. Hypercalcemia is an important effect because we use thiazide diuretics in patients with calcium oxalate and calcium phosphate stones, because we are essentially reducing the calcium excretion by the kidneys, and you prevent them from having the kidney stones. Hyperuricemia leading to gout is a known effect, once again more prominent with loop diuretics. Hyperglycemia, so hence you want to educate your patients about diabetes control, getting out, get with blood sugars going higher, and they might end up needing more insulin or more medications. Hyperlipidemia, and once again you want to educate your patients to get a fasting lipid panel checked in few months. And lastly, this is very under, I think, talked thing in the clinical practice, but a real thing, which is it can increase the risk of skin cancers because it impairs the DNA repair mechanisms. Hence, for patients who are at increased risk of skin cancers, like somebody who has already history of a skin cancer, patients with lighter skin, and those who are exposed to sun all the time, you want to recommend them to use sunscreens. Okay, what are the evidence behind using these medications? So as I said in the beginning of my talk, the two medications, one is the chlorthalidone and second one is the indapamide, is where we have the most of our data. Chlorthalidone, the trial that you want to remember, or the name of the trial that you want to remember, is called as all hat trial. That is all hypertension trial. It included the chlorthalidone as well as calcium channel blockers and the ACE inhibitors. Compare A comparison was done, and chlorthalidone was a proven to be a very potent antihypertensive. Second one is indapamide. It has two different trials. One is for hypertension in very elderly patients, and second one is an advanced trial which was mostly in patients with diabetic disease along with cardiovascular diseases and hypertension, and indapamide was noted to be a potent antihypertensive. So in my opinion, if you want to go by an evidence based medicine recommendations, you try first chlorthalidone or indapamide, although for some reason hydrochlorothiazide seems to be very commonly used in practice, which is not wrong. The one difference that I have seen in my clinical practice between chlorthalidone and hydrochlorothiazide is hypokalemia is more potent with chlorthalidone compared to hydrochlorothiazide, and hence maybe that's the reason it is more, little bit more potent thiazide diuretic compared to the hydrochlorothiazide. What are the common dosages that we use? For hydrochlorothiazide, you can start off with 12.5 and slowly increase the dose to 25 or up to 50. For chlorthalidone, you have 25, 50. I have seen in my clinical practice, depending on the body size, patients going up to 100, but got to be a little cautious. And indapamide is a 2.5 or 5 milligrams. One of the benefit of using indapamide would be in patients who have sulfa allergies. That's all I have for you. Thank you for subscribing. Stay tuned.